Welcome. Dr. Davis is a professor of colorectal surgery at LSU. He completed his medical training at the Quillen College of Medicine and completed his surgical residency at the William Beaumont Army Medical Center in El Paso, Texas, where he also eventually served as the program director of general surgery and chief of general surgery. He completed his fellowship in colon and rectal surgery with the Georgia Colon and Rectal Surgical Associates in Atlanta, Georgia. Dr. Davis served for many years in the Army, earning the rank of colonel, and retired from the Army in 2016. He's had numerous publications and book chapters on the topic of colorectal surgery. Please join me in welcoming Dr. Davis today as he teaches us more about the management of large bowel obstruction.
Well, thank you very much. It's a pleasure to be here. This when I received the invitation, I was like, oh, that's this is a favorite topic of mine because it's pretty easy to talk about. Two, this really falls within our realm. This is and I'm going to talk a little bit about, the difference, between small and large bowel obstruction, but large bowel obstruction, this is 100% within our purview and almost 100% within the colorectal surgeon's purview. And the other nice thing is you're not going to hear me mention, maybe once or twice, randomized controlled trial. There's not a lot of literature out there. So it's kind of, what we're going to do it this way because that's the way I think we ought to do it, kind of a thing. So so the objectives of this talk are pretty simple. I'm going to go over the most common causes of large bowel obstruction. I'm going to talk about the evaluation of large bowel obstruction, which is very straightforward. And I'm going to talk about the management. And the management is almost always surgical. It is relatively simple. And I'm just going to touch on a couple of the controversies. So it always kind of drives me crazy when people, and it's usually, general surgery residents, but sometimes even some faculty will use the, term bowel obstruction and almost interchangeable. And the two diseases are very, very dissimilar and they're managed very dissimilar. And I think that, and it kind of reminds me of the difference between mesenteric ischemia and ischemic colitis. And we're actually I'll touch on ischemic colitis a little bit. They are very, very different and they are managed very, very differently. And when I was a general surgery resident, we used to talk about never letting the sun rise or set on a bowel obstruction. And now I think small bowel obstructions are really managed non-operatively, much more so than they are managed operatively. And large bowel obstruction, not so. Large bowel obstruction really falls within our purview as colorectal surgeons. So just to recapitulate a little bit, small bowel obstructions are, for the most part, from adhesions and hernias. And when we talk about hernias, because there are some hernias that cause large bowel obstructions, but it's typically not inguinal or femoral hernias like with small bowel obstructions. And also Crohn's disease, but that's much less common. And malignancy, almost never. I mean, you will probably see a case or two of malignancy causing a small bowel obstruction in your career, but it is very uncommon. Large bowel obstruction, I mean, really the big three are colon cancer, diverticulitis, and volvulus. And then, you can throw in IBD and ischemia and endometriosis. But I mean, when you look at the causes of this, I mean, you very quickly see, there's a chapter in the ASCRS textbook on pretty much every one of these things. And large bowel obstruction, really should, in my opinion, belong to the colorectal surgeon. So the presentation is not subtle. The patients present with abdominal distension, a little bit of pain, some obstipation, and and they have tympany. And the thing you don't see on this list is nausea and vomiting. And because patients typically, if they do have, sometimes they'll have nausea, but they will almost never have emesis. And when you get the call, the ER doc is always like, "Oh, do you want me to put an NG tube in?" And I'm always like, "If they're not throwing up, why are we going to put an NG tube in? Just to make them miserable? I mean, they already feel bad." So um, it um, the workup is pretty straightforward, and I still think there's a place for plain films, a flat and upright. And when you read papers on this, you will see NG tube, contrast enema, and endoscopy. But I really think it's really imaging. It is CT scans are so good, they're so prevalent. The patient is already going to, I think the biggest problem is that the CT scan will be done without any contrast medium in the intestine. And I think that if you can put a little bit of contrast down, a little gastrographin, I think it is beneficial. But usually just an IV contrasted CT scan is more than enough for you to get an idea of what's going on. So the management, like I said, these are managed surgically. So, and the nice thing is you usually don't have to rush these patients off to the operating room. You've got some time to slow down and figure out what exactly you need to do. And that gives you time for fluid resuscitation, correcting the electrolytes. And these patients, a lot of times, have some profound electrolyte abnormalities. And then as you begin that resuscitation process, then it gives you time to evaluate and then treat the cause. It usually is not a big diagnostic dilemma of what you are going to find when you take these patients to the operating room. Unlike with a small bowel obstruction, where it can, sometimes be, you know, a little bit of well, I think it's going to be this, but with a large bowel obstruction, not so. So emergent operation, I mean, the reasons to operate emergently are the same as for almost any other abdominal complaint: perforation, peritonitis, ischemia, gangrene. And the gangrene is really more in the volvulus when we talk about that. If you're doing endoscopic decompression and you see gangrene, that's an indication for just taking the patient to the operating room. But that is uncommon. So, and just a quick refresher, because I'm sure everybody remembers the law of Laplace, which is that a long pliable tube, the side of the largest diameter, requires the least pressure to distend. And that's the cecum. And so the cecum is the most common site of perforation. We tend to use 12 centimeters as kind of the magic number, but it really is not written in stone, I think, like we used to think. But it is important to kind of monitor that and to look at it and to think about it. I think the bigger thing is that when you do have to operate on some of these patients, and we'll talk about it in just a second, is that I have a much lower threshold for taking out the right colon when someone presents with an obstructing transverse or splenic flexure lesion. And it's because that proximal colon will be so dilated, and you know that when it gets so dilated that it is a little bit ischemic. So colon cancer, without a doubt, this is the most common cause of large bowel obstruction. It's probably about half of large bowel obstructions in this country. And still in this day, 10% of colon cancers present with a large bowel obstruction. It has a very high mortality, around 15 to 30%. Um, it The big question always comes, because for the most part, and we'll talk a little bit about palliating in just a second, is do I put this patient back together? And that is, if there's any ischemia, if there's perforation, I think the answer is no. And then sort of it depends on the location of the lesion and how dilated and what the quality of the bowel looks like. These patients have they're an acceptable leak rate, 3 to 5%. I think that number is low, but again, you're not going to find any large randomized studies. My tendency is to not put these patients together, but I certainly have on more than one occasions. And I think it really depends on just the quality of the bowel and how the patient is doing. What about unresectable disease? This is something that we run into not uncommonly. It's carcinomatosis, or patients who are unstable, that when you operate on them, you find an unresectable phlegmon. It is perfectly acceptable to just do a proximal diversion on these patients. There have been a couple of small studies looking at doing a proximal loop colostomy, which is a horrible ostomy. I hate a proximal loop colostomy, and it really is only in my hands a bailout. And I thought that it's a very old study, but I thought it was interesting that 3/4 of these patients actually went on to resection and closure, which to me, I was like, gosh, I'm not sure, why they really needed a proximal loop colostomy to begin with. And then a study looking at over 120 patients that they actually randomized to staged versus acute resection, and they found similar recurrence and survival. I think these patients are. I think this is a very difficult patient population to randomize, and I think, to me, that my preference is to do a resection. I don't like leaving the malignancy in situ. And then my default is to divert. But if the patient is doing well enough, I have no problem putting them back together at the initial operation. So just briefly, I'll touch on colon lavage, and I put Dale Carnegie's book, How to Win Friends and Influence People, because I think if you want people to hate, if you want your OR staff to hate you, by all means, do colonic lavage. I have only been involved one time. It is a mess. For those of you who have never done it, you have to mobilize the entire colon. You have to take down both flexures completely. Either do an appendectomy or just put a purse string into the cecum and put in like a Foley. And then you have to tie in corrugated anesthesia tubing into the descending colon with like a vessel loop. And then you instill 3 to 6 liters of warm saline into the cecum, and that is running off of the table into several buckets that the circulating nurse then has to deal with. Um, it's it is a mess. It is a mess, and the results are not very good. There aren't very many studies, but the wound infection rate is high, and there was one randomized trial, and it was stopped because the results from lavage were so bad. So there are still surgeons who do it. I mean, at your fellowship, you might have, some old gray-haired colorectal surgeon who still does lavage. More power to them. But like I say, I've been involved one time. I'll never do it again. So what about stents? And stents, I think stents kind of, wax and wane a little bit in popularity. And I know when I was going through my fellowship, stents were very popular. Um, and when you look at the studies, and most of the studies are single institution, um, and the perforation rate is all over the place, anywhere from 0 to 80%. The perforation rate is much higher if you do it with a balloon. It's higher in patients that are on bevacizumab, um, and it can be very effective, especially for palliation. So, but as I say, most of the studies are single institution. So when you actually look at a few of the randomized studies, which have been in Europe, um, the technical success rate is much, much lower than you see in some of the single institutions where they're like, oh, we did stenting and we were 98% successful. When, you know, the few randomized studies show that it is successful 50 to 70%. The stoma rate was equal, which the whole reason that we're supposed to be doing this is try to prevent the patient from having a stoma, and up to a 20% perforation. And these are patients that you really don't, I mean, you never want to have a perforation, but I mean, these patients are sick and you're trying to palliate them. A lot of times these are patients that have already lost weight, and it can really be disastrous. So I think that stenting has a role. I think it has a very good role. I also think it's interesting that the ASGE rather, recommends that stenting only be performed for a patient that is a poor surgical candidate. I think that there, without a doubt, is a role for stents. I haven't put one in years, but I think that when it is successful, it's great. But I think that unfortunately, a lot of times the tumors are not, located where it's easy to get a stent across. Um, and I haven't done one in several years. And I would approach with caution, is what I would say about stenting. So for palliation, the Mayo experience, they had about a 1 in 4 complication rate, and that the metal stents are more associated with complications. But those are the ones that are going to be better suited for palliation of malignancy. So what about diverticular disease? So this is, in this country, the second most common cause of a large bowel obstruction. Around 10 to 20% of large bowel obstructions. Our options from a surgical standpoint are really pretty similar to what they are for malignancy. And that is a patient with diverticular large bowel obstruction. You can resect the disease and give them an ostomy. You can resect the disease and give them an anastomosis. I think that I am probably more liberal with putting these patients together for diverticular disease than I am for malignancy. And sometimes you can't tell. That's the one thing is you take them to surgery, and other than the anatomic location, because they will, a lot of times these patients will look like malignancy, and you'll be like, gosh, is this cancer or is it diverticular disease? Um, it the if you are leaning toward diverticular disease, or at least if I am, I'm much more apt to put these patients together because I'm not worried about them uh, needing to get adjuvant therapy, as opposed to a patient with a malignant large bowel obstruction. When those patients have a complication and they wind up being in the hospital, that you're delaying potentially their definitive treatment, what they really need, which is adjuvant therapy. So with diverticular disease, that's not the case. And we all hate doing Hartman takedown. Nobody ever likes doing that operation. So I have a much lower threshold for putting these patients back together. So, what about inflammatory bowel disease? This one's pretty uncommon as far as a cause of large bowel obstruction. You will see it, but not very often. Usually, these are patients that that already has existing inflammatory bowel disease, who's undergoing treatment, or who has been non-compliant with their treatment. Um, if possible, I try to get these patients on therapy, but a lot of times these are treated with a resection. So hernias, you do see hernias as a cause of large bowel obstruction, but it's uncommon. You don't really see it as the groin hernias, the femoral, or the inguinals. It's more commonly a large incisional hernia, where and again, those are treated uh, with possible resection, and not try. These are big hernias that are not going to be fixed at the index operation. You're just trying to relieve the obstruction, and then you can put in vicryl mesh. But to me, this is going to require a complex abdominal wall reconstruction, and that is not the time to be doing that in the face of an obstruction. Go in there, fix the obstruction, and get out. Intussusception, uncommon in the large intestine. The most common is small bowel. You will sometimes see ileocolic intussusception. I've seen it twice for large polypoid lesions, both times in the transverse colon, and the last one I was able to do it laparoscopically, and because they tend to desuscept, and and then I think it's managed just like any other lesion. So ischemic colitis is much more common, I think, than we realize. The example that I always use is, in every large or medium-sized city in this country, at least once a year, there will be a handful of healthy people who develop ischemic colitis on the same day. And we usually don't get called about those because they're handled in the emergency department. It's when the marathon comes to town. And if anybody's a runner, they'll know exactly it. The colon is not high priority for getting the blood flow when somebody's out there doing something crazy for 3 or 4 hours. And most runners don't even think anything of it. They empty their bowels. They don't really, they're not really looking to see that it's bloody. But it certainly can be. And you'll have a couple of patients that go to the emergency department with pain, and they'll get a CAT scan, and you'll occasionally get a phone call. They'll be like, yeah, this healthy person, they were, running the marathon today, and they had pain, and the CT scan shows, ischemic colitis. I don't know. And you're like, okay, just give them some fluid, give them a little bit of antibiotics. They're otherwise healthy. They're going to be fine. So, and I'm not sure really how important the IV antibiotics are in this day and age. We've gotten away from antibiotics for so many things like diverticulitis, but the recommendation is still IV antibiotics, and I still do it. So, but these patients, now, if it looks like the one on the right, clearly that is a different set of ischemic colitis. Most of the time it's patchy, and I do endoscopy up to the point where I see I don't go past it. I get very nervous when I scope up and I'm seeing a little bit of ischemic changes. I just photo document and I back out, and then I monitor the patient. If they have ischemia that looks like that, that's going to warrant a resection. I do not put these patients back together. Every one of these patients gets an ostomy in my hands. Endometriosis, a horrible, horrible disease. And where I did my fellowship, I had the misfortune that there was one of the regional experts in endometriosis. So we got involved in a lot of these surgeries. The lesions can cause significant luminal narrowing. And if they are large lesions, they're treated with segmental resection. Lesions that are not on the intestine are typically just treated with laser or cautery. It's a lot of times we will get called in as the gynecologist is like, well, you know what I mean? It's like clearly there's a bunch of scarring in the cul-de-sac. And so we get called in to mobilize the sigmoid and descending colon. And that's really our total involvement in it, unless a resection is required. And if there is a large lesion on the colon that's causing puckering or narrowing, those are best treated with segmental resection. Metastatic disease is very uncommon to cause large bowel obstruction. Ovarian cancer is probably the most common cause of metastatic disease. It can cause significant morbidity and mortality. There is a little bit of evidence that resection is associated with extended survival and improved quality of life. These are usually done in conjunction with GYN oncology. A lot of times, at least, where I've been, most of the GYN oncologists don't call us for a lot of this. They tend to handle it themselves. But these are never very rewarding cases to perform. So now volvulus, and volvulus is probably the most common cause of large bowel obstruction worldwide. We don't see as much of it in this country. There's an area in Africa and India called the volvulus belt, where it is much more common. And and if you think about it, volvulus we don't see it as much here because we have diverticular disease, which we think is a result of not eating enough fiber. In the places where individuals eat a large amount of fiber, they have enlarged colon with more loose mesentery, and the bowel can twist. In this country, probably 10 to 15% of large bowel obstructions. They typically cause a closed loop obstruction, which makes the treatment more urgent. Sigmoid is by far the most common, but cecal, transverse colon, which I've never seen, and iliosigmoid knotting, which I've definitely never seen. So sigmoid and X-ray, I was always taught that X-ray was diagnostic, but when you actually look at the numbers, plain film is not very good. CT is very good. I was also taught that you could detorse these with a rigid proctoscope. And I've certainly had experience of trying to do that in the emergency department, which is never a fun thing. Honestly, now I do it with a flexible endoscope. Because a lot of times the rigid proctoscope, you cannot get high enough to detorse it. And we are all so much more comfortable with flexible endoscopes and the techniques. And you're not putting your face down there at the business end of what can very often be an explosive when you do detorse. I never even attempt it with a rigid proctoscope anymore. So we talk about colonic tubes. I think that trying to find one at every institution that I've, has not really worked out. You can put an NG tube down, but to me, they're just not long enough. It's if the patient is stable, these are managed with endoscopic decompression, and then at the same hospitalization, the patient is taken for a segmental resection. I have never attempted to plicate or do anything along those lines. The management that I've always done, and I continue, is just a segmental resection. And these patients tend to do pretty well, as long as you are doing that in an elective. If you have to emergently take them and resect them, these patients typically are a little on the older side and have quite a few medical problems, and they're not the patient that you want to be doing an emergency colectomy. And if I do, then those patients are getting diverted. So cecal volvulus, only about 1% of all, and this diagram shows the clockwise torsion of the cecum. There are really kind of two variants. There's this one, and then there's the cecal bascule. And they're kind of two age peaks. This variant tends to be in older patients in the 60 to 70. The cecal bascule, which is here, it's the folding up on itself. These tend to occur in younger patients, 20 to 30. Again, to me, these are just treated with resection. People talk about cecopexy. To me, it is a relatively straightforward segmental resection, and that's what I do. Transverse colon volvulus, again, never seen it, has a very high mortality. It is usually associated with patients with prior abdominal operations. I think that the high mortality was probably related to delay in diagnosis. I think now with CT scan, if you pick up on this, it is managed surgically, but the most of what you see in the literature are case reports, and they tend to be older, and I think it was a little bit more of a diagnostic dilemma with it. If you see someone that you think has a transverse colon volvulus, you just need to take them to the operating room. The operation is extended right hemicolectomy. So iliosigmoid knotting, again, never seen it. This it's called the double volvulus. I think it's one of the craziest things. The sigmoid uh, colon gets, kind of strangled by, another segment of intestine. It it tends to happen in during Ramadan. It follows a single large meal, which is the individuals are fasting all day. They eat in the evening. They eat their large meal, and then have a very sudden onset of exquisite abdominal pain, and present, and it's got the double volvulus sign. Uh, I was in Iraq a couple of times, and I was like, I'm gonna see this. I'm gonna be ready. I'm gonna be the only one who knows what's going on. When I never saw it, but I was ready. I was like, oh man, somebody's coming in, and and I'm gonna know what it is, and I'm gonna lap them. So it uh, they talk about not trying to detorse this, but to resect both segments. And the reason is because if you attempt to detorse, a lot of times you will release a lot of the inflammatory mediators and the cytokines, and that it is best treated with just resecting the four pieces of intestine and then putting it back together, or in the case of the colon, diverting. And most of the time you find gangrenous bowel, but sigmoidectomy is safe in the few studies that have looked at it. So volvulus, it is it is common, and volvulus is definitely something that you will see. And it's something that you definitely as a colorectal surgeon need to be prepared to treat. So, and then finally, the non-operative cause of large bowel obstruction, and I know that we try to get away from eponyms in this day and age, but I still like to use Ogilvie was a military guy. I was a military guy, so and to me, I think one of the most impressive things is he actually worked out the pathophysiology long before the testing was available, which to me is pretty impressive. Pretty common. You definitely see this. It tends to be in hospitalized patients who are a little on the older side, and it happens from unopposed parasympathetic activity. And as a result, it's treated with neostigmine, which is a parasympathomimetic, and a peg to prevent. Now that is polyethylene glycol that I realized when I was looking at this. I was like, it's kind of a poor little thing. It's to choose. That's not a percutaneous gastrostomy. That is polyethylene glycol to try to prevent recurrence. A lot of times the patient does develop recurrence. And so I might, the first thing I like to do is the neostigmine. And then if and when they um, develop a recurrence, then I like to perform endoscopy. And I have one time performed a tube cecostomy. I don't think I will ever be tempted to do that again. Now I'm like, no, just manage them medically with neostigmine and endoscopy if necessary. So that is large bowel obstruction. And I'm happy to answer any questions if anybody has it. It again, it's there's not a great deal of good literature out there on large bowel obstruction, but this is 100% within our wheelhouse.
Great, thank you for that talk. It was very comprehensive, and I think we all learned something new today with the sigmoid nodding. Um, first question is, what are your thoughts about stenting a patient, like maybe like a malignancy, but stenting the patient as a bridge to being able to prep them, resect the same admission, maybe avoid an ostomy, lower your leak rate?
Yeah, I think that that is where a stent is at its best, but and I've done it successfully, and then I've attempted that um, and then made it worse. So because I think stenting is one of those things that if it works, great, then you've done yourself and the patient a huge favor. But if it causes perforation, I think that you've actually made the situation worse. And I think the perforation rate is a lot higher than I used to think when I was a fellow, and because we were very big on stenting where I trained and did several. Um, and I I think that I'm not as high on it as I used to be for that very reason. I think that if it works, without a doubt, you can do that. That you can decompress the proximal intestine. You can then bowel prep the patient. It's sort of like you would, for a sigmoid volvulus. It's like you detorse them, great, clean them out, and then take them, and you can do that surgery laparoscopically. With malignancy, it's a lot of times you just don't know what you're going to get into. And once you kind of get started and you start going down that path and you're putting a wire across the lesion, and then especially if you have to balloon up, um, it I'm just not as high on it as I once was. I think without a doubt it works, and when it does work, it's great. And you're like, oh my gosh, that was so wonderful. But when it doesn't, I think it makes things worse.
When, if ever, do you think it is safe to take a laparoscopic approach as opposed to open? And if you are going lap, what approach would you use to get in?
So I think laparoscopic can. I think it's just like any other. I think laparoscopic can be done for if you're more patient than me. I think that I think it really depends on how much dilated intestine that you've got. I think that if you have a patient with a hepatic flexure, cancer, and you're really only dealing with the ascending colon, yeah, I think those are great to do. I think if you've got somebody with a distal sigmoid lesion and their entire colon is dilated, um, I just don't feel comfortable, mobilizing that ascending colon, because it's already so tenuous and so dilated that the thing I'm petrified of is making a perforation. And so I think that, and then you can always start laparoscopic. I mean, it's, you can, make it, put a couple of trocars in, look around, see, and it's like, look, if it's not going to be amenable, okay, then you make an incision. I never have any heartburn with that. Um, as far as where to get in, um, it's I think it kind of depends on where you think the pathology is.
Okay. Um, for diverticulitis, you mentioned being more prone to putting the patient back together. When do you decide whether or not you divert them proximally with an ostomy, with like an ileostomy? Do you ever do that?
I had a partner who was really big on doing that. Um, Again, I'm not a huge fan of giving someone an ileostomy, and and the reason for that is because if they leak, then the ileostomy doesn't help you that much. It's because and then it's kind of confusing. It's sort of analogous to a patient if you ever see someone with a rectal stump blowout, and you're like, gosh, they're diverted, but they just stay sick. And then you have interventional radiology put a drain in. And so if you think about, if you've got a patient with diverticulitis and you perform an anastomosis, they've got an entire proximal colon full of stool. If they leak, that stool is going to come out. And there's no IR drain known to man that will adequately drain that. And you'll have a proximal ileostomy, and you'll be like, well, gosh, you know what I mean? The ileostomy's working, but the patient's still sick, and you scan them and then you drain them, and then then you're 2 weeks later, and then ultimately you wind up having to take them back, and a lot of times then give them a second ostomy. And man, then you're like, wow, then you're really questioning your life choices. It's you got a patient with an ileostomy and a colostomy, um, and and you're not really high on their hero list.
I see. So if you're worried enough that you think you'll need to divert them proximally, you'll just
then
give
I
them Hartmann's.
then I give up. Then I do a Hartmann's.
Got
It's
it.
because I have been involved with that, and then if you give them an ileostomy and then they don't, then their anastomosis doesn't leak. Well, okay, then you know what I mean. And the majority of them won't. So then why do the ileostomy? So if I'm really worried, then I give them a colostomy. I just
So at a lot of hospitals, it seems like a LBO is a emergency general surgery case versus a colorectal case. Where do you think that line exists where it should be one or the other?
yeah, I mean, I think that I mean, my personal opinion is these should belong to us. I think these are now, I mean, if you're, at a place that you don't have a lot of colorectal, but to me, I think these are ours. I think that, and I think that it's not that general surgeons don't have the knowledge or the skills. I think that some of it is kind of the subtle differences in managing some of the different conditions, and then the techniques to do it. I think that we are probably more apt to put patients together. I think that we are probably more apt to do an anastomosis. And I think that we're it's not to say that, the general surgeons can't and shouldn't manage these conditions, but I think that, it all falls with, under our umbrella. So, but again, I suspect in the surgical lounge, I would get a lot of pushback from some of my general surgery colleagues.
I mean, I think even following up afterward, beyond just that admission, it's nice to already know the surgeon that you're going to go see.
100%. I mean, that's just it. They all, you know what I mean? They like to send the morbidly obese, multiple medical problem Hartmann to us to take down. And then you're always kind of like, you're looking at it going, I'm not sure I would have given this patient Hartmann's. I might have, put them together. So to me, if you're gonna, if you're gonna be involved, you know what I mean, just involve us from the beginning.
Another question for you is for let's say you have a patient who has unresectable malignant disease. What is your take on, like, what is your decision making in terms of what kind of colostomy you're going to do? Do you ever do a blowhole like through the transverse? Do you ever do a proximal colostomy?
Yes, I think that my thought process is to try to get as distal as I can upstream from the malignancy. And I am much more liberal with blowholes now than I used to be. And again, it's kind of like, and I used to think, well, gosh, as long as they, have a patent anus, it'll all go downstream. But that's not the case. And again, that So a lot of times I'll kind of do a mucus fistula, because in addition to the colostomy, which I don't like doing mucus fistulas, and for an obstructing cancer where the cancer is left in situ, it's one of the times where I will. And I'll do it kind of like I do for a rectal stump, in that I'll sew it in, just above the fascia, that I'll incorporate it so that if it does blow out, then essentially it's already kind of a ready-made ostomy. So, but I try to get as distal on the bowel as I can, but I'm very liberal with, and I've done a turnable blowhole a couple of times. It's never been a great experience, and maybe it's just I haven't done enough of them to, but the patients are always very sick, and it's always very difficult.
Circling back to the stenting, we did get a
Yeah.
question asking how long you would wait between stenting and operating.
So I think it sort of depends. I think that, to me, one of the better places where the stenting, where it works best, is for rectal cancer, and where you can stent and then get the patient neoadjuvant therapy. I think that if you successfully are able to put a stent in, there's nothing pushing you to operate urgently. I think that I wouldn't wait months, but I think if the patient's malnourished, then that is the time to, try to get them nutritionally, optimized. It's and then I would try to operate on them when they are as good as you can get them in a few weeks. But if they're actually stented, there's nothing that's really pushing you. And then I would, clean them out, uh, have them on a low residue diet, and, do, insures or whatever. And then I would try to do it minimally invasive.
I think that's the end of our questions. We would just want to say thank you so much for spending this
Absolutely.
Sunday with us on the holiday
Absolutely.
weekend.
Absolutely.
And
Thanks
we
for
really
having me.
appreciate your time. Of course. Thanks so much.